All right, everyone, it's the top of the hour. We'll get started. I'm Dia Wagasback in Houston. I'd like to welcome you all to our GlomCon seminar series. Today's talk is titled The Renal Pathology of Checkpoint Inhibitors. And you're in for a treat today as we have a group from Mayo Clinic presenting. Our speakers today are Dr. Priya Alexander, renal pathologist and associate professor of laboratory medicine. Her research interests are in glomerular diseases, which were guided under her training with Helmut Reinke. Her interests largely focus on native renal disease with chief contributions from the discovery of the DNA JB9 in fibrillary glomerulonephritis. Her current studies are aimed at understanding the molecular basis of native renal disease with extension of that understanding to allograft pathology. And she has numerous publications, and we're excited to have her back again on GlomCon. Joining her today are Dr. Sandra Herrmann, Associate Professor of Medicine and Consultant in the Division of Nephrology and Hypertension at the Mayo Clinic. Dr. Herrmann's research interests are focused on the nephrotoxicity of cancer immunotherapies and mechanisms of hypertensive kidney disease. Our third speaker is Dr. Aleksandra Kukla. She is also an Associate Professor of Medicine and Consultant in the Division of Nephrology at Hypertension in Mayo Clinic. Dr. Kukla is a transplant nephrologist with interest in pancreas transplant, obesity, and diabetes and transplant recipients. All of them have numerous publications, and we're excited for them to share their knowledge with us today here on GlomCon.
Thank you very much, Dr. Dia. It is a privilege, and thank you for inviting us to speak today. Our topic is on the renal toxicity associated with immune checkpoint inhibitor therapy. Immune checkpoint inhibitors are a novel type of immunotherapy that have changed the landscape of management in oncology, and it is a substantial advance. This is characterized by the use of monoclonal antibodies that are designed to target the inhibitory receptors that are expressed on immune cells and tumor cells. The receptors that are targeted include cytotoxic T lymphocyte-associated antigen 4, program death 1 protein, and program death ligand 1. Now, the immune negative regulators of the immune system have been designed as part of the immune homeostasis with the intent of preventing self-reactive T cell antigens and autoantibodies from destroying the host tissue. And it is using these natural homeostasis mechanisms that the targeted antibodies have functioned to allow immune reaction to damage and destroy tumor cells. Now, the CTLA-4 is normally present on T cells, and it tries to compete with CD28 to prevent and downregulate T cell activation. T cell activation is normally through the T cell receptor when it identifies peptides that are presented by the major histocompatibility complex, and there has to be a co-stimulation with CD28 and B7. So CTLA-4 tries to compete with CD28, and when it does so, it inhibits the activation of T cells. So when you use a monoclonal antibody that is targeted against the CTLA-4, you have a continuous state of T cell activation or overstimulation, and as a result, you have a hyperimmune system which is utilized to destroy tumor cells. Similarly, in the more peripheral tissue or organ system, there are the PD-1 and PD-L1 negative regulators of the immune system. For example, here you have an activated T cell immune response where the co-stimulation is taking place. But when there's an excessive chronic persistent antigen stimulation or chronic infection, the use of PD-L1 as expressed by antigen presenting cells and PD-1 by the T cells down-regulates or decreases the proliferation of T cells, diminishes cytokine production, and diminishes cytotoxicity. So there are antibodies designed to prevent this down-regulation, and that causes an effector T cell immune response in the local organ region. So it is this theory that has been utilized by the novel therapies that are being used now to prevent activation of to allow overactivation of T cells and destroy tumor cells. And here you see that the activated T cell is working against the tumor cell, and the antibodies are preventing the normal negative regulators from controlling the environment. So you have an overactive immune system. So what is the mechanism? That by targeting these lymphocyte receptors or their ligands to unleash the anti-tumor response, you have immune reaction destroying tumor cells. CTLA4 and PD-1, PD-L1 receptor blockade regulates these immune responses at different levels. The CTLA4 really regulates the activation of antigen-specific T cells in the lymph nodes. And this is evident with mutated mice studies where mice that have knockout of the CTLA4 have a lymphoproliferative process, whereas mice that have a knockout of PD-1, which is more in the organs, have a more autoimmune or a more organ-based autoimmune response. So the mechanisms of action are different between CTLA4 and PD-1 and PD-L1. Now, so far, this is the list of FDA-approved drugs and immune checkpoint inhibitors that have been authorized for use. And as you can see, the immune checkpoint inhibitors have transformed the landscape of management of several solid organ malignancies and hematological malignancies. The main ones, which include melanoma, non-small cell carcinoma of the lung, renal tumors, urothelial tumors, to name a few. And these are targeted against the drugs are targeted against CTLA4, they targeted against PD-1 and PD-L1. But with this process where the immune system is hyperactive or overstimulated and under-regulated, it is, as you can imagine, a double-edged sword. And that is what is being noticed more and more with the use of this novel therapy. Now, immune-related adverse events imply the immune response that affects other organs that are not meant to be targeted by these novel therapies. And as a result, there are several organs that are affected. Immune-related adverse events can occur in as many as 50% to 75% of patients who are receiving these drugs. And they affect a host of organs. The very common ones are dermatitis, colitis, diarrhea, but you can also, and you can have pneumonitis, you can have thyroiditis, vasculitis, and along with that, the kidney has also been noted to be impacted by these drugs. The common manifestation of this is acute kidney injury, but as we have more and more data being accumulated, we realize that acute kidney injury can be due to many processes, which include acute interstitial nephritis, acute tubular injury, glomerular pathology, and in the transplant setting can also include rejection. So what are the mechanisms that underlie immune-related adverse events? The first is that when you have, as has been shown in the prior diagrams that I showed, you can have a hyperactive immune system with a T cell reactivity. And these T cells are active against the tumor antigen, but they can also react against self-antigens on healthy tissue. And that's how you may get myocarditis, pneumonitis, thyroiditis. Another feature that has been noted is that with the activated T cells, there is a component of a humoral process that is activated. And this results in an increased level of pre-existing antibodies that may have been there at a very subclinical level, but in the system of impaired homeostasis, you have autoantibodies such as anti-thyroid antibodies. A third mechanism is that these antibodies, these immune checkpoints that are being present on the immune cells and tumor cells can also be normally expressed on other organs. For example, in the pituitary, you have CTLA-4 normally being expressed. So the anti-CTLA-4 antibody that is being used as therapy is also non-specifically attacking other organs, such as the pituitary, and you can get hypophysitis. With the antigen-antibody reaction, you can have a complement-mediated damage that further accentuates the tissue injury. And of course, as you know, when T cells are overreactive, there is, in the process of proliferation, a host of inflammatory cytokines that are also being produced. So when you come to the kidney and the kidney-related immune adverse events, the mechanism is not entirely well established and needs a lot of basic science processes to truly understand these mechanisms. But the broad hypothesis is that it is a breaking of immune tolerance by unleashing quiescent tissue-specific self-reactive T cells that are many but are normally downregulated by the checkpoints. You can also have an emergence of antigen-specific T cells against self-antigens. You can also have a process of haptenization where the drug-reactive T cells may combine with tissue-specific T cells and then result in an immune mechanism that targets the specific organs, such as the kidney. Now, kidney toxicity from these agents is relatively uncommon as compared to colitis and dermatitis. Kidney-related toxicity is less, and it can be 5% or less. But acute kidney injury can be seen in as many as 17% of cases. But this could be due to cancer, other, dehydration, other cancer-related cachexia, and purely related to immune checkpoint inhibitors, it's believed to be only 2 to 5%. Proteinuria and hematuria can also be seen. So when it comes to acute kidney injury, we see that due to the actual checkpoint, it's 2.2% to 5%. Largely, it's within that range that you have immune checkpoint inhibitor associated damage. Acute interstitial nephritis with all the data that is available is the most common renal pathology that is seen, and it mirrors acute interstitial nephritis as one sees in drug-related acute interstitial nephritis. The patients present with pyuria and subnephrotic proteinuria, and this can be seen in up to 93% of immune checkpoint acute kidney injury biopsy pathology. It can be seen in isolation, or it can also be seen with other glomerular diseases, which include pauciimmune, IgA nephropathy, and other pathologies. And in 25% of acute interstitial nephritis, you can get granulomata. There is a variable time course from the exposure to the immune checkpoint inhibitor to actual presentation with acute interstitial nephritis. This can vary from 21 to 245 days. And sometimes checkpoint inhibitor associated acute kidney injury can be seen as many as 63 days after the last checkpoint inhibitor dose. And this behavior or this pattern that we see points more in line with an immune-related process. So what are the mechanisms of the most common pathology that we see, which is acute interstitial nephritis? It is antigen-specific T cells breaking self-tolerance and triggering an autoimmune response, or even a loss of tolerance to effective T cells that were primed due to a prior drug exposure to PPIs. And this heterogeneity, as I mentioned, points to an immune response or an immune reaction. Acute tubular injury can also be seen, and in one study has been seen in 42% of those who were biopsied for immune checkpoint associated acute kidney injury. The exact mechanism is unclear, but it possibly is related to an underlying vascular disease that primes these patients for kidney injury. Glomerular diseases have also been seen, and this is a summary of several of the case reports and case series that have been associating glomerular diseases with immune checkpoint inhibitor therapy. And they range from minimal change, membranous nephropathy, lupus nephritis, Autoimmune glomerulonephritis. And I'm going to just touch on a few. So minimal change disease, as we know, is due to a circulating factor which impairs and damages or causes podocyte foot process effacement, and has been attributed for a long time to a T cell process. And here are the podocytopathies that have been complicating immune checkpoint inhibitor therapy. They may occur as early as within a little more than 10 days, 2 weeks, to as many as 18 months after exposure to the drug. Autoimmune glomerulonephritis has also been seen in the setting of immune checkpoint inhibitor therapy. These are more associated with small to medium vessel vasculitis, and in a rare case has been associated with an actual crescentic autoimmune glomerulonephritis. The vast majority are ANCA negative, but some are reported to be associated with MPO and PR3 positivity. And in some cases, there have been associations of undetected prior positive PR3 antibodies, which were quiescent, but with the use of immune checkpoint therapy, these have become activated and have come to become characterized by organ disease. And this is a summary of literature that is available on vasculitis in use of immune checkpoint therapy. Lupus nephritis has also been seen, or lupus-like nephritis has also been seen with the use of immune checkpoint therapy. And these patients have been quiescent prior to the initiation of the immune checkpoint therapy protocol. There was no proteinuria. And a short while after initiating the drug, patients present with proteinuria, their ANA and dsDNA are positive, and the biopsy shows a immune-mediated process. So here's another example of a glomerulopathy where membranous nephropathy occurs in the setting of immune checkpoint inhibitor therapy. And you might ask, well, it could also be that membranous nephropathy could be activated secondary to the malignancy. And in fact, that is true. But if you look at this example of a mesothelioma, the patient had mesothelioma but had no proteinuria. It was only after initiation of the immune checkpoint inhibitor that there was increase in proteinuria. And then when you used therapy against the antibody with rituximab, the proteinuria declined. Now, this knowledge is very important to understand the hypothesis as it guides how the nephrologist is going to manage these patients. With the use of immune checkpoint therapy, you can have up to a third of patients having pre-existing rheumatic or autoimmune diseases having a flare-up because of the humoral activation following immune checkpoint therapy use. And this is more commonly associated with anti-PD-1 and PD-L1 as opposed to CTLA-4. But you can also have de novo antibody production. This is another example of thrombospondin positive membranous nephropathy that was associated with immune checkpoint therapy use. And for the sake of being brief with lack of time, this is just an example of the serum that was used to detect antibodies to THSD7A, where this is a negative control, this is a positive control. The patient prior to the use of immune checkpoint inhibitors did not have circulating serum antibodies, but this point is when the antibodies were detected, and it corresponds to the use of immune checkpoint inhibitors, supporting that a humoral mechanism is also unleashed with immune checkpoint inhibitor therapy. And complement-mediated glomerulopathies is also not escaping from the processes that occur with the use of immune checkpoint therapy. And so as data aggregates, we will see more and more and of glomerulonephritis and other renal pathologies. And it really is critical to have a deep understanding of these. And endothelialitis in the native renal biopsy has also been reported in the setting of use of immune checkpoint therapy. So in summary, immune checkpoint inhibitor therapy is a novel transformative type of therapy which targets lymphocyte receptors and their ligands. The immune-related adverse events can be due to immune hyperactivation. Acute kidney injury is a recognized immune-related adverse event and can be seen in as many as 70% of patients. However, the actual pathology related to an immune-related adverse event in the setting of immune checkpoint is within the range of 5%, and the spectrum of disease includes acute interstitial nephritis, acute tubular injury, and a spectrum of glomerular pathology. And the pathology in the transplant, as we will see, includes acute tubular injury, but also increased rejection. Thank you, and with that, I move on to Dr. Sandra Herrmann will be presenting.
Thank you, Priya. Just to start with share the slides. Let's see if I can. It is from. So can you see it? Okay.
Yes.
Okay. So as Dr. Aleksandra has presented, I'm just go from now and just talk about some of the other renal immune-related adverse events. And she beautifully talked about, in addition of acute interstitial nephritis, other types of glomerular pathologies, immune checkpoint inhibitors. So it's not uncommon to see those type of pathologies. The most common is interstitial nephritis. And from the glomerular pathology, we can see post-immune vasculitis and podocytopathies have been described. Particularly, the only case I've seen as vasculitis here in our institution. We had seen other cases of IgA flare, a patient with pulmonary cancer who had developed a type of henoxin-like pause at the set of the cancer, and they had a flare when started checkpoint, but it did well with therapy. But following those common pathologies, the other pathologies have been described. Some are probably and very well documented related to the immunotherapy. Here's just an example of the case. We had here a patient who was initially developed AKI, right away starting cemiplimab. And then when he got the treatment, he was rechallenged again. He was doing fine, but the patient was an elderly patient and he was tired of taking steroids and stopped. And then he developed the significant endotheliitis, an example. So it's something to really keep in mind, this population. Other abnormalities seen in the immune-related are the electrolytes abnormalities, and this is recent report where the Rina Von Schuh had looked at the FDA database of adverse events related to electrolytes by medications, and as you can see here, it's very common things with any other cancer agents, hyponatremia, hypocalcemia. You can expect the patients who have a CTLA-4 inhibitor treatment, they might present with significant more hyponatremia because they develop a lot of GI immune-related adverse events. And they are followed by the PD-1 and PD-L1 inhibitor as well. So hyponatremia, hypocalcemia are the very common electrolytes abnormalities seen in this population. Hypercalcemia also has been described. And going for how those electrolytes abnormalities may be related to the ICI, here's just an example, as Dr. Aleksandra described it, patients who have CTLA-4 inhibition, they might develop pituitary dysfunction, they can have isolated anterior pituitary dysfunction, or have other hormones deficiency related to ICI endocrinopathies. Thyroid dysfunction is something very common. If you treat those patients, they always, many of them, they develop initial thyroiditis and then followed by hypothyroidism, and they are placed with low thyroid hormones. This is a type of ICI, immune-related event that's very common, but usually can be just managed with replacement. Adrenal dysfunction has been shown and usually occur with at least a couple of cases that I've seen here. They have developed with other immune-related adverse events. And all those types of ICI endocrinopathies, they can cause hyponatremia. From this report from the MGH group, they have reported that sodium abnormalities, as you can see here, why they divided below 134 was more than 50% of patients develop hyponatremia. But the more severe hyponatremia, thankfully, it's a less proportion of these patients. But we really dig in and check, are they ICI related, or could be for other causes. There is very small amounts that they could see that's related to endocrinopathies. In our group, we had seen patients who had present hypokalemia and also associated with acidosis. They also for the investigation, we found they had renal tubular acidosis, most particular distal renal tubular acidosis. And you notice this, the patient come with some hypokalemia, they start to become acidotic. And not necessarily you see that the patient has a more significant AKI, usually it's mild AKI. And then when you have the chance to biopsy these patients, because the AKI is getting worse, you see that they also had the interstitial nephritis. Particular here in our group with Dr. Zahn, Dr. Romero, Aleksandra, we have the chance to have 2 patients with kidney biopsies, and we look we label the tissue with immunofluorescent labeling for particular markers of the VATPases. And as you can see here, the patient with control, they have unexcited changers related to intercalated cells and also subunits of VATPase. They all had the antibodies with decreased expression. And you can see this is a similar mechanism as the patients who have Sjogren's disease that has been described in the past by Caster-Gardner. And this shows how the mechanism of autoimmunity developed in this population. So it's something that you have to pay attention, especially if you're a patient with immune checkpoint AKI. Has mild, look to see if they have hypokalemia, acidosis, they might develop distal renal tubular acidosis. Hypercalcemia also has been described. There is several types of potential mechanisms that can be caused and has been described, but particular could be related to thyroids or also ACTH. But what mostly you can see and describe in the literature as well as patients develop sarcoid-like granuloma. Particularly, I haven't seen outside, mostly it's lung-related sarcoid-like granuloma causes hypercalcemia, but commonly seen patients with cancers, high PTH-related peptide that they can also have as a cause of hypercalcemia. When you treat those patients, they have presented with some hyperprogression disease, and this can be seen commonly in this population. And they might also present with AKI because of a significant hypercalcemia, and we had a couple of cases in this scenario. So those are types of abnormalities you can see in these patients. How to diagnose the immune checkpoint AKI? Ideally, if I would ask to all oncologists have obviously baseline laboratory, which they usually have for this population, but sometimes they forget to have routine analysis, which can be quite important, especially if the patient is just presented with the nephrotic syndrome and not much change of the creatinine. But obviously, in addition of the electrolytes, urine analysis, protein to creatinine ratio is important, especially for the follow-up after the development of ICI, AKI. Here at Mayo Clinic, we try to order all the patients' CRP, serum C-react protein, as well urine retinal bind protein to creatinine ratio. I'm going to discuss a little bit about these biomarkers. Imaging studies to rule out any kind of obstruction or structural dysfunction the kidney could have. PET scan has been helpful to also give a hint the patient could be develop a immune checkpoint ACI. And obviously the gold standard kidney biopsy should be considered when you cannot really pinpoint that is related to immune checkpoint AKI. Regarding the biomarkers, we did this single center studies where we look at the patients from 2014 to 2020. We divide these patients who had the most likely immune checkpoint AKI, and this was patients who had the biopsy confirmed with acute interstitial nephritis or other glomerulopathies if he had, but in our cases, they all had acute interstitial nephritis. And if you could not biopsy, this should be attributed to immune checkpoint, and usually it's related if you give the steroids and they resolve. Those who didn't have immune checkpoint AKI was those who had a biopsy confirmed not be AIN or other glomerulopathy, and we consider ATN as being one of those biopsies. Or those patients who didn't have progression of the AKI, but they didn't have worsening of the creatinine, or they resolve creatinine after holding the immune checkpoint for a period of time. So as you can see here, the average creatinine in the population with immune checkpoint AKI was a little higher than those who didn't. So those are really the population that many times they send to you with the creatinine baseline 0.8 to 1 milligrams per deciliter, but then just slightly increase, and the oncologist will already send to you, but do you know if they have immune checkpoint AKI without the biopsy? What has been very helpful that in this population, most of the time, the CRP, usually it's quite elevated in the patient who have immune checkpoint AKI versus those who didn't have immune checkpoint AKI. And the urinary retinal bind protein to creatinine ratio is quite elevated in the population with immune checkpoint AKI versus those who don't. Usually the normal ratio is around 170, and but the average those who had non-immune checkpoint AKI was much lower. And as you can see here, outcomes, most of the patients respond, and our criteria for complete recovery was just 25% back to baseline. Many were rechallenging, and recurrence occurred just in 20% of this population. Here more in detail, when we have those patients who have both, we did a log of the CRP versus urinary retinal bind protein to creatinine ratio, and you can see that it's much more elevated patients in immune checkpoint AKI versus those who didn't have. So you can say that retinal bind protein is a non-specific marker because ATN can also cause, but if both markers are normal, especially those with a very mild elevation of creatinine, that shows that most likely, unlikely this to be to related AKI, and then you can, save the patient and kind of just postpone immune checkpoint therapy, see if it resolves the mild AKI, and then go ahead with therapy. And usually the patient does well. PET scan, as described before, it can be useful if a patient for some reason cannot get a kidney biopsy and you still have doubts what's the cause. As you can see here in this patient, they have FDG prior to immunotherapy at the time of the AKI, and B and C after resolution of the AKI that was related to immune checkpoint inhibitor. The only caveat, one of the caveats of using this as a resource, because FDG, as a patient have AKI, they're gonna excrete less and they can retain more. So that's something you have to discuss with your nuclear medicine folks to see what they particularly think, if that could be related to the AKI per se or to the a possible immune-related event. Also, the dose and patient's weight can interfere, but it can be a adjuvant tool for use for diagnosis of immune checkpoint AKI. So when consider biopsy in this population, so usually the patient had significant AKI, we always consider kidney biopsy unless there is some contraindication such as increased risk of bleeding. If you cannot pinpoint what could be the potential, another etiology or a laboratory test. If the patient, for example, had another immune-related adverse events like pneumonitis, and he's gonna receive treatment with immunosuppression therapy, you might consider not doing immune checkpoint AKI and just consider just go ahead and treat this population. But usually patients with immune checkpoint AKI, they usually have another immune-related adverse event at the time, and around 40, almost 50% have another had or have associated at the time of the AKI immune-related event. And so that can give a hint as well. I usually consider biopsy, the patient had like a stage 1 AKI, not quite stage 2, but they have presence of a renal tubular acidosis if they have elevated biomarkers, or they are presented with a nephrotic or nephritic syndrome that would make me consider kidney biopsy. And how do you manage these patients? Obviously, you're going to try to remove all the potential culprits like the ICI per se or any other drug that potentially can cause acute interstitial nephritis like PPIs or NSAIDs. Usually, if the patients have a more severe AKI, stage 3, IV steroids is a consideration. But most of the cases of the diagnosis are stage 2 or a little bit lower. We try to start with 0.8 to 1 milligram per kilogram of steroids, and I usually taper 10 milligrams every week to get 20 milligrams, and then 5 milligrams every week until 0. So this approximately give 2 months of treatment. But other authors, like from MJ, they have done short course like 6 weeks, and the patients also have responded well. But this depends in terms of how patient reacts to the immunotherapy and also half-life of the drug. It's important if you're going to treat these patients for more than 2 weeks with high dose of prednisone, obviously to give PJP prophylaxis. I usually prefer pentamidine because of Bactrim can be associated to AIN cases. GI prophylaxis, since you are discontinuing PPI, some patients may require, and they're going to ask you to have some other time protection, and H2 blockers have been used. I usually try to give the highest dose because when you remove PPI, you can have rebounding symptoms, and that can be quite distressful for patients. For resistant cases, as Dr. Aleksandra has reported cases, are cases that have membranous nephropathy or glomerulopathies, other types of immunomodulatories, immunosuppression has been used, mycophenolate mofetil, but I would prefer something more target therapy, like rituximab has been used with success with some patients. TNF blockade, interleukin, or interleukin-6 blockade also has been considered. Which challenge can be considered, I'm going to discuss more, but usually you can do with the same drug, or some cases you can switch the class if oncology recommend this could be done as well. Here, just for you to have an idea, some patients can receive immune checkpoint inhibitors and have a good response and last long for many, many years or many months as well. But for you, just have an idea here, the half-life of these drugs can be up to close to 1 month, as shown here in pembrolizumab. As you can see, so sometimes I prefer, most of the time, prefer to treat these patients long-term, because as you're tapering too fast, they can have a recurrence of the AKI, and then you know you have to prolong on immunosuppression therapy. It's good to know those drugs are cleared primarily by non-specific proteolytic degradation in the plasma and in peripheral tissue, so there is no issues with excretion. And also there is no contraindication of patients with undergoing dialysis as well. Just showing some of the cumulative incidence. So when you see those patients who do develop AKI and you start treatment with him, approximately 40% of those patients, they have completed response. And in this case here in our study, we consider going back to baseline serum creatinine and no more than 25%. So they were very close to the baseline creatinine and 40% reached that. But if you consider partial recover, they can go up to 80%. They do have complete or partial recovery. Some are rechallenging and some, progress to their disease. The only issue of these patients, as you can see, the GFR at the time initiation with checkpoint AKI is much higher. But if the patients develop a significant AKI, especially severe AKI at the year of a year, they invariably they're gonna lose kidney function at the time at 1 year follow-up. Why is it important then consider and diagnose this population right away? Because if you can avoid the patient have severe AKI, you can have a higher likelihood to the patient reach renal complete recovery. And this has been reported in the past, has implicated in terms of overall survival in these patients. For those who don't have renal recovery, they do worse. So in terms of how do you manage these patients in terms of diagnosis? Usually this patient is stage 1 AKI. You can consider checking the biomarkers, and if you don't have how to check the biomarkers, you can consider just observe, hold them on checkpoint AKI. If the progresses, obviously, hopefully they'll be seen by a nephrologist, what they can further evaluate and consider treatment, especially if they have other immune-related events like pneumonitis and myocarditis, that they have to get the immune checkpoint AKI. And hopefully that will resolve. If not resolve, we can consider kidney biopsy at that point. But you can consider, if appropriate and don't have any other immune-related adverse events, to go ahead and do a kidney biopsy and treat appropriately if it AIN, give immunosuppression therapy. If ATN, usually you would wait to resolve and consider a re-challenge at some point. So most recently, from the group from Bingwas, Dave DeLeaf and Shruti Gupta, we have described very challenged patients, and so I couldn't put in this table. But there was, prior to that study, there was several reports and studies that have described the immune checkpoint patients who develop AKI, they can be re-challenging, and around 20% of this patient have recurrence AKI. Re-challenging has not been shown to change survival. We had to look at this particularly in those patients, excluding those who had death or hospice, but they seem to have a trend to do worse. But it's hard to evaluate these patients because most of the time when these patients with challenges because they don't have any other option and the cancer can be just aggressive. But again, going back to the Gupta's paper, they did evaluate these patients. There was an international multicenter study where they had 429 patients with the acute checkpoint related, immune checkpoint related AKI. 35% of these patients were re-challenged, the group who had renal recovered, and 18% in the group who didn't have renal recovered, which was considered here 1.5 times the baseline creatinine. They also found that around 16% and those who have renal recovered developed immune checkpoint AKI recurrence, and around 80% in the group who didn't have recovered. So overall, most of these patients, patients who were re-challenging, they did well, and they had been, this re-challenge has done under a dose of corticosteroid most of the time, 80% or higher. And the incidence of AKI shown here with stage 2 and 3 being the most common after rechallenge. They also evaluate terms of survival after rechallenge and show here, they didn't remove any patient who progressed disease here, but they put all comers and evaluate after 9 days of immune checkpoint AKI and 108 days, and they didn't see any difference in terms of survival in this population. So how I manage this patient, this is personal opinion, but when the patient presents with immune checkpoint AKI, obviously you have to see if there was biopsy proven, and you treat it with corticosteroids and wait until the AKI resolves. If that resolves, you consider rechallenging. Yes or no. If it's no, I usually would, and most of the time oncologists, they would not recommend the patient had severe life-threatening immune-related events, adverse events such as myocarditis or cytokine release. But if they didn't have that, they should, consider rechallenge with the low dose of prednisone, usually use 10 to 20 milligrams of prednisone. I follow then checking creatinine 1 or 2 weeks post immune checkpoint rechallenge, and things are going well, we can consider even spaced time. If the patient develop immune checkpoint recurrency, then you can probably not rechallenge and treat per ICI treatment guidelines. And if they don't have recurrence of the immune checkpoint AKI, you follow for 1 or 2 cycles, and then you can consider slowly tapering prednisone and see if then on recurrence they could continue on checkpoint rechallenge. So in terms of summary points, early diagnosis is paramount to allow early intervention and prevent severe AKI, as you can see, is related to the outcomes. If patient have normal CRP or urinary regional bind protein to creatinine ratio, less likely to be immune checkpoint AKI. So you may forego kidney biopsy, but if creatinine is not improving, consider kidney biopsy if there is no contraindication, especially if they have elevated biomarkers. And immune checkpoint AKIs is usually respond well to steroids. Most of the patients have at least complete or partial recovery, but some may need some immunomodulatory approaches, and rechallenge is quite feasible in some patients. So I'd like to thank you and stop sharing.
Thank you very much, Dr. Herrmann, Dr. Aleksandra. I will go over the issues with using checkpoint inhibitors in our transplant population. Let me share the screen. Can you hear me okay?
Yes, looks good.
So this is Dr. Kukla, and I appreciate this introduction. I am interested in obesity and other things, but the checkpoint inhibitors used in transplant recipients is also very close to my heart, because we do see increasing number of patients who are coming with cancers. And those cancers are a lot worse than what we see in the general populations or in patients who are not on immunosuppression. We see mostly cancers associated with some sort of viral reactivation, and non-melanoma skin cancer, especially squamous cell cancers, are very highly prevalent in our patients. And some patients will do quite well, and they will visit with their hematologist and get cancer removed and will go on with their lives. But some patients will develop this difficult to treat metastatic disease, locally invasive with lots of meds. And we really do not have a lot of options for these patients. And it's not unusual for us to see the patient, let's say 1 month, and we know that once we schedule the follow-up visit in 3 months, they will no longer be there. So we really need very effective therapy for these patients. And unfortunately, The immunotherapy is just not one that has been studied in transplant patients. All of the transplant recipients have been excluded in clinical trials because there is this concern that once you unleash immune system, so beautifully described by Dr. Aleksandra, the immune system is going to attack then your transplanted kidney and destroy the transplanted kidney. And that's transplant patients are so very protective of their transplants that many times they would choose not being treated with the novel therapies than risking the kidney. So any data is good. Currently, we have very limited data, and I will go over what we have so far. But I still hope that we will continue to work with our transplant recipients and increasing the clinical trials for these patients. So as briefly mentioned before, the cancer-specific mortality is higher in transplant patients than non-transplant controls. The increase in mortality was particularly high for patients with melanoma, and the checkpoint inhibitors are very effective for melanoma cancer. But also we do see that for other cancers, and cutaneous squamous cell carcinoma, especially metastatic ones, advanced, is also checkpoint inhibitors are also very effective for this disease. So our patients are dying, and they're not dying because of the graft problem or going on dialysis, but they're dying because of the comorbidities. And this graph represents our recent work that was led by our previous fellow, Dr. Merskani, who looked at the causes of graft loss. And after 5 years post-transplant, patients are dying with the functioning graft. So there is either cardiovascular disease, malignancy, or cancer, which is a cause of death. And this is the brief summary of our findings. And interestingly, malignancy took a front line. So for patients who are more than 1 year post-kidney transplant, the cancer is the major cause of death. And that is even more common than infections and cardiovascular disease. So we have learned how to evaluate the patients pre-transplant. We know that we have to do the thorough age-appropriate cancer screening. We know that we have to look at the risk factors for cancer. We learned the correlation between induction and maintenance immunosuppression and which agent is better to minimize the risk of post-transplant malignancies. But that's where we're lacking. We're lacking at treatment, and especially we're lacking at using a novel immunotherapy like checkpoint inhibitors in our patients. With that in mind and seeing some of these patients, we have decided to look at our series. And this is data from Mayo Clinic 3 sites, so including our site in Rochester, in Arizona, and in Florida. We identified patients who were treated with checkpoint inhibitors. And interestingly, we only were able to find 7 kidney transplant recipients in addition to some livers, and only 2 heart transplant recipients who were treated with these agents. The major cancer that was identified in this population was squamous cell carcinoma, 29%, but also we have seen hepatocellular carcinoma because we did have liver transplantation. Interestingly, all patients had surgically unresectable disease and metastatic disease to several places, and all patients failed other lines of therapy. So these were the patients who were treated with checkpoint inhibitor late when other therapies were extensively exhausted. And not surprisingly then, the death was quite common in this population. We saw that 65% of our patients died during the follow-up period, and roughly only 40% or so had some sort of response, either partial remission, complete remission, or stable disease, while approximately 60% of patients had disease progression, cancer disease progression. We did see some of the autoimmune manifestations. Couple of patients, one patient had colitis, and also there was one patient who developed heart failure, and this was a heart transplant recipient. Rejections happened in 3 patients, 2 liver transplant, but interestingly only 1 kidney transplant recipient. And when we did this competing risk analysis of outcomes, the cancer progression was the earliest and more frequently occurring event, comparing to, for example, graft rejection or failure. And perhaps these patients eventually could have developed graft rejection or graft failure. However, in this competing risk, that they were having problems with cancer progression. This was the major cause of their death. But the numbers were small, and just like in any other single center analysis, we can only identify, I would say, mostly case series. So getting any conclusions from such a small number of patients is always challenging. So this was the effort led by Dr. Murakami, and she created the Immune Checkpoint Inhibitors Consortium to study these issues in solid organ transplant recipients. And the 23 transplant centers participated, and all of us have sent the raw data. So it's not meta-analysis, but the raw data of the patients, which does allow us to understand more what happened with the patients, what truly were the outcomes, and collect the same data across all the centers. And study design included the clinical safety, meaning incidence, timing, and risk factors for acute graft rejection, as well as response rate and overall survival, specifically in patients who had the cutaneous squamous cell carcinoma and melanoma, mostly because these were the most common cancers that were seen in these populations. What was novel for this project was that Dr. Murakami included a comparison group. And these were the patients who were also kidney transplant recipients, but who were not treated with checkpoint inhibitors. So they were treated with other therapies, but just not checkpoint inhibitors. Interestingly, we were only able to identify 69% patients across 21 centers. So as you can imagine, again, very, very small number of patients are offered checkpoint inhibitors therapy across all transplant center programs. These were older patients with the age of 65. The cancer type was mostly squamous cell carcinoma in majority of those patients, followed by melanoma. And the time between transplant to initiation of checkpoint inhibitors was roughly 9 years. The next question that we are always asked is what to do with immunosuppression. And that was also very variable across the centers. A lot of patients would have their CNI discontinued. A lot of patients had CNIs changed to mTOR inhibitors. Also, a lot of patients, in addition to change in CNIs, had their anti-metabolite, so mostly CellCept, discontinued as well. Some of these patients had increased dose of prednisone, so some centers would increase prednisone from 5 milligrams to 10 milligrams. There was also one center who would use a small pulse of steroids before initiation of immune checkpoint inhibitors, but it was really difficult to make any good conclusion just because the number of patients in each center was very small. When we look at the outcomes of these patients, disease progression was seen in approximately half of the patient, while the other half had either complete response, about 7% of patients, partial response, 15% of patients, or stable disease, or 21% of the patients, or stable disease in approximately 15% of the patients. Rejections were present in about 40% of patients treated with checkpoint inhibitors. Now, not all the patients were biopsied. So we had a total of 29 patients who were considered to have rejection just because they developed acute kidney injury. And only 14 patients underwent kidney biopsy, while about 15 patients did not. When we look at the pathology in these who were biopsied, about 50% had mixed T-cell mediated antibody-mediated rejection, and about 50% had the pure T-cell mediated rejection. As far as the treatment, not all the patients were treated. Only about 30% of patients among those who did not have a kidney biopsy received steroids, and about 78–79% of patients who were biopsied and were diagnosed with acute rejection received steroids, while the other 3 patients, or 21%, were treated with nephrectomy. So when does the rejection happen? In majority of the patients, if rejection would happen, it will happen about 1 to 3 weeks post initiation of immune checkpoint inhibitors. And then the farther out you are from the treatment, the less likely that this rejection would happen. This is also interesting analysis of survival, overall survival here on the left side, which compares the patient who developed rejection versus those who did not. And if you can probably appreciate, there was no difference in overall survival in kidney transplant recipients who developed rejection due to checkpoint inhibitors comparing to those who did not. On the right side here, we see the patients who ended up initiating on dialysis versus those who did not have acute kidney injury, so no rejection. And again, there was no difference in overall survival between these 2 groups. Among all the available data that we have, we found that using sirolimus, mTOR inhibitor, was beneficial for these patients. And this is in terms of allograft survival. Patients who were on mTOR inhibitor here in the solid line did overall better than those who were not on mTOR inhibitors. And also, this is for the depth sensors, and also with mortality. And overall patient survival was not affected by rejection or initiation on dialysis. Next, we compare the patients who had the squamous cell carcinoma and received checkpoint inhibitors, and those who had squamous cell carcinoma and did not receive checkpoint inhibitors. So here ICI group in blue and non-ICI group in gold. And we saw the improvement in outcomes. We saw the improvement in overall survival, as well as disease-specific survival in patients who received immune checkpoint inhibitors comparing to those who did not. When the same analysis was done for patients who had melanoma, we could not appreciate the difference, but the numbers were somewhat smaller. So again, just to summarize the acute rejection risk, and this is something that we are asked repeatedly by the patients and referring oncologists. Based on the available data, we tell them that the rejection risk is approximately 40%. And the type of rejections that patients may get, it's either mixed acute and antibody-mediated rejection versus pure T-cell mediated rejection. The time to rejection usually between a month, but 1 to 2 weeks is most often when rejections happen. Patients who do develop rejection are at increased risk of graft loss. However, saying that not all the patients in our cohorts were treated. So we don't know how the outcomes would be if we would attempt to treat these patients with corticosteroids, just like it is done for their autoimmune diseases. And what we can say based on the data is that mTOR inhibitors are likely protective and is associated with overall less risk of rejection. So this is the summary that transplant patients with metastatic squamous cell carcinoma treated with ICI had better survival comparing to control group not receiving ICI. We know that mTOR inhibitor is likely a good thing, and probably, and especially for patients with squamous cell carcinoma, should be considered when initiating on ICI therapy. Rejection can happen in about 40% of patients, and those patients who develop rejection may have 60% risk of graft loss. However, saying that these agents are feasible for our kidney transplant recipients and perhaps should be used more often. Currently, many oncologists consider kidney transplantation a contraindication for immunotherapy, but it very well may be beneficial, especially in those who have very advanced or metastatic disease. Now, as far as the timing, when to start it and how to protect our patients so they won't start on these therapies when they're really at the verge of hospice, when disease is so advanced that the likelihood with any treatment is going to help, it's a question for another research. So we critically need the prospective studies, ideally randomized control in the transplant population, to answer all these questions. So the key points to take from our three presentation is that immune-related adverse event could be due to immune hyperactivation. Dr. Aleksandra beautifully presented that there may be many pathologies for patients treated with checkpoint inhibitors. That includes, and probably most common, acute interstitial nephritis, but also ATN and glomerular pathology. Transplanted patients likely also have very variable pathology. We are just not able to show it because in many instances, these patients are not being biopsied, and as I showed in our paper in KI. However, I would encourage everyone who is taking care of transplant patients starting on ICI who develops acute kidney injury to biopsy these patients, because that's the only way we can learn and potentially help these patients by starting some sort of intervention, whether there is a steroid treatment or just like recently I saw the patient who developed a severe ATN, and this patient was on mTOR inhibitor at that point. We did take her off because the anti-proliferative features of mTOR inhibitors and kind of manage her conservatively, stop ICI for the time being, and her kidney function recovered. Now, whether these patients can be ever rechallenged, that's another question for another research. The most important for the kidney transplant recipients is to sit with the patient and discuss the goals of therapy, because there is central risk of adverse events to the allograft. However, patients who may need to go on dialysis but improve in terms of malignancy and hopefully prolong their lives because of the treatment may prefer to do so. Thank you for the opportunity to present, and please, if you have any questions, we will be happy to answer.
Thank you. Thanks to all of you for an excellent and comprehensive presentation on the immune checkpoint inhibitors and spanning kind of all of our patient populations and what we see. So that was excellent. For some of the questions in the chat, I've posted some links to some articles and review articles, some of which were referenced today for you guys to take a look at too and have as references. If you guys are okay with it, we'll stick around for a few more minutes to answer some of those questions. So one of the questions that or comments that came up was kind of similarities between immune checkpoint inhibitors being administered and then the symptoms and relapses we see with certain GNs, and then also with immunizations. And if there's some, you nicely presented the immune pathways, but if you could comment on any observations from regarding that.
I think the basic principle is the same, in that anytime you are intervening with the normal homeostasis, you have different pathways that are activated, and they could be overreactive T cells and Also, the humoral pathways can be activated, and it is hard to say which is dominant, but I think that is, in a sense, what is happening, and the similarities that have been questioned are likely the same process, with a vaccination and GNs that were either quiescent and then became activated with the immune modulation, so to say, or is it de novo? Hard to know. You actually have to have data over a long period of time. These are all definitely associations, but there certainly is an understandable mechanism that would align with both these processes. So, yeah.
Thank you. And I think along with that, I believe that's Dr. Rogvi behind the wheel there. So I ask him to unmute. He has his hand raised.
Can you hear me?
Yes.
Yeah. So yeah, I am the wheel today. Trust me, it's better than how I look right now. So I have this PPI story is really interesting to me. So I have two simple questions. One is, when you re-challenge people with checkpoint inhibitors, at least from a renal standpoint, they do really well. They may not do well overall because that may be a selection bias, but their renal system, they don't get a lot of as much AKI as you think. Do we know in the patients that are re-challenged, how many were originally on PPIs and then when re-challenged were not on PPIs? Because that may be the big difference here. And then the second question I have with that in mind, and I probably already know the answer is no, but would anybody ever consider in a mild AKI that's on a PPI, stop the PPI, give them a little bit of prednisone and don't stop the checkpoint inhibitor? And I'll mute myself.
Yeah, there's a great proportion. Somehow in patients with cancer, a lot of the patients are on PPI because they get, they get GI upsetting, and the first thing they give is PPI. So a lot of them are on PPI, and we have a term. We try to stop PPI for everyone. Start with AKI that's referred to us, and then you might just observe if it's just a mild AKI like you did, and we did that for many patients, stop PPI, just observe. But if it's really an immune-related event in general, it doesn't get better right away. We try to biopsy those patients if it don't get better and they have the biomarkers elevated and go. But most of the patients that we stop PPI, there's some patients that are discussed by phone, and then they come to us, the oncologists do not discontinue PPI, but we try to discontinue PPI for all of them. As several studies and most recent Shruti has shown there's a high association. Causation, we cannot really say, but there is studies going on, probably preclinical studies looking at these factors.
And then we have another question from Dr. Essay here.
Thank you so much for this elegant talk, and thank you for your time over the weekend. I have two questions. Number one is for Dr. Kukla. In your cohort, 29 patients of cohort, transplanted patients with immune checkpoint inhibitor, in the rejected patients, did you observe graft intolerance syndrome, which is basically painful enlargement of the transplant, which requires sometimes nephrectomy or ablation? And number two, for Dr. Herrmann, what's your protocol for the prednisone? Like, how many days do you treat as a preventive measure, as you suggested, as an expert opinion? Thank you so much.
Excellent question. I will take the first one. So to be honest, I do not know whether they had a graft intolerance syndrome. Those patients were returned to dialysis and they were from many centers. So in my own experience at Mayo Clinic, we have several, and we have not experienced a lot of rejections. I have to say, currently I actively follow about 4 or 5 patients who are on immune checkpoint inhibitors, which I think is a good number comparing to how little or how small number from other centers are. And we are very aggressive in starting those patients on high dose of mTOR inhibitors. So our Sironimus level runs 12 to 14, that high. And I have not observed rejection. Now that's the biased opinion, I would say, because again, we would need a lot more patients to prove it. And our data does prove that mTOR inhibitor is beneficial in other centers too. but maybe because of that, I just don't see those rejections. And so I didn't put patients on dialysis, and I couldn't observe what happens after that. But that's a good question. I'll turn it to Sandra now.
Okay, hi, nice to see you again. Your question about rechallenge or just the normal, the treatment?
Just, I don't know whether do you use prednisone in the first, like after an AKI episode, and if the patient recover, I think for the next challenge, do you use prednisone?
For us, at least for us, we always give prednisone. At least here, we try to give prednisone. There is other reports people have just try not to give prednisone, and it might work. But my question with those reports, were they really immune checkpoint AKI? Did they have interstitial? Did they biopsy, or they just treat that could have been an ATN? For our patient, we always try to give prednisone, and I start, if it was severe AKI or they had another immune-related event, oncology, or let's do 20 the first week and then drop right away, just because they were concerned they have immune-related. But most of the time, you just do 10 milligrams. You do that first cycle, see how the things are going. Do a second cycle, and if things are doing fine and the creatinine has not bumped up, because many times, as the question, they were on PPI or they take an NSAID. Sometimes there is something they got it that might have triggered, and then we say they are off that, and then you try to slowly taper. You can start with 1 milligram or 5. It all depends how you're comfortable, and but usually try after the second cycle, taper the prednisone, and some just do fine.
Thank you so much, Dr. Herrmann. Good to see you too.
All right, thank you. A couple more that came in from the chat, and then if anyone else has a question, please speak up. One regarding the RTAs, and Dr. Reen had commented on, do you see RTA and then does that develop into an AIN picture, or have you noticed any of those kind of correlations or
the cases we have seen here, they are noticed they have RTA with mild AKI, creatinine may be increased by 30% or something, and then they had the hypokalemia and acidosis, and then the creatinine starts slightly, we just stop ICI, and then the creatinine start going up. So in the cases that I've seen after that I start paying more attention, they start to have hypokalemia and acidosis, and then you just observe. You can try to give another dose of checkpoint AKI if there's no AKI, but usually they flared up. So some cases you see early on the RTA come first. Obviously they probably already have an AIN, but it's not clinically or creatinine highly elevated. But I think that might start first.
All right, thank you. And then a question about risk factors for patients that to develop this. So is there anything we should be screening or thinking about in certain patients before they get immune checkpoint inhibitors? Kind of talked about the questions that come from oncology for the transplant patients before they're given, but anything in CKD patients or things you're looking for that may predispose them to toxicity?
So yeah, there's some associated factors besides the drugs. Patients who have CKD, baseline CKD, probably because they have low reserve, they might be prone to develop AKI as well. There are factors that they might be, and if they have another immune-related adverse event, already you might be, at risk to develop AKI. It's just a fact because they are developing immune-related events.
Thank you. And then there was a question about kind of clarification of how you distinguish membranous from the cancer versus the immune checkpoint inhibitor. Dr. Aleksandra, if you could take that one. I think you're muted.
That's a great question. There are only few reports currently that have drawn the association with immune checkpoint inhibitor therapy and membranous nephropathy. One was with the PLA2R associated membranous, and the other was with the thrombospondin associated membranous. With regards to the thrombospondin associated membranous, serum at the time of the actual diagnosis of cancer diagnosis, there was no evidence of antithrombospondin antibodies in the serum. And it was only detected when the immune checkpoint inhibitor was initiated. So that is why there is a suggestion from that paper that it is most likely associated with an immune stimulation or a modulation that occurred with the use of the immune checkpoint inhibitor. Is that the fact? Well, that's the data in this single study, which definitely seems to suggest that it was the therapy that was associated with an upregulation of maybe quiescent antibodies to the thrombospondin antigen, which is, as you know, also on the podocyte as well as in the tumor. So that's with regards to that membranous study. The other one was in a patient who had mesothelioma and had no evidence of proteinuria when the mesothelioma was diagnosed, and it was detected, the proteinuria was noted to be increasing only after the use of immune checkpoint inhibitor. And it's true, you know, what is the causation, what is the association, but beyond that, understanding that is important, but more importantly, I think, is understanding how do you treat these patients? Because if you understand the background of it, you know, for example, in the patient with mesothelioma, they use rituximab, which is different from just stopping the, you know, allows you to continue the treatment for the cancer, but also allows you to use another arm of therapy that addresses the membranous. So I think these are studies that need to be, we need more long-term data, we need more mechanistic studies, but based on what is available, this is what I can understand, and I think this is the importance of it. So hopefully that helps answer something.
Yes, thank you. And then I think just we'll do these last two. One about the benefits of switching to an mTOR inhibitor. And is there any benefit to that? And maybe Dr. Kukla can answer that.
Sure. So this is for the transplant patient. So I'm looking at the question based in cancer metastatic patient. Does that mean Dr. Pace for all the type of cancers? That's what you had on mind? So perhaps I take it as yes. So the only data that we have is for squamous cell cancers. However, we do try to switch patients with other cancers as well. So we are still learning, but because of squamous cell cancer is the most common, followed by melanoma, and for melanoma we also switch this patient. We have the most data. Now, whether that would be true for other cancers is hard to say. We know that in kidney transplant recipients who are de novo on mTOR inhibitors, the incidence of overall skin cancer is less comparing to those who are, for example, on de novo CNIs. Similarly, we also know that in the early studies, if you have only like 1 or 2 incidents of cancer, squamous cell cancer, and if you switch patients from CNI to mTOR, the following that the incidence of more skin cancer is less. So there is something about sirolimus and squamous cell carcinoma that we know. So perhaps that's the reason why we're getting better results in patients with already metastatic squamous cell carcinoma. I do not know about some other cancers, but hopefully once we have more and more patients on checkpoint inhibitors, we will learn that as well.
Thank you. And lastly, how often are you monitoring for proteinuria after starting immune checkpoint inhibitors? Do you guys have any standards or things that you guys are following to check these patients?
In general, oncologists, they don't monitor until you develop AKI. It's already, we hope that at some point the patient, ideally, at least what I have asked that oncologists, if they can get a UA before it started, that would be great, even for future studies. But in general, they do not order unless the patient develops an AKI.
All right, thank you. I'd like to thank everyone for staying over time to answer all those questions. And it was another great session. Appreciate having all of you guys on and all of our audience for participating. So thanks for spending part of your Sunday with us. We will not have GlomCon next week, next Sunday because of ASN. So we'll see everyone the following Sunday. So thank you all very much.
Thank you.
Thank you, Dia. Thank you, everybody.